Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers, producer of Public Health on Call. As 2024 winds down, we acknowledge that we're facing a lot of unknowns in 2025. This podcast started in a moment of extreme uncertainty in March of 2020. Since then, we've worked to bring context, evidence, and personal stories to critical public health issues, and we remain committed to being your regular dose of informed discussion. Thank you for listening, for writing to us, and for being with us on this journey. We're taking a much-needed break for the holidays, and we'll be back with new episodes in January. As always, please keep sending your ideas and questions to publichealthquestion@jhu.edu, and we'll see you in 2025. Today, Dr. Otis Brawley, a Johns Hopkins Bloomberg Distinguished Professor and epidemiologist, returns to the podcast. He talks with Stephanie Desmond about the ins and outs of mammography and breast cancer, including the biggest question of them all: do mammograms save lives? Let's listen.
Otis Brawley, thanks so much for returning to the podcast.
Oh, thanks for having me.
So I want to start with a big question. Do mammograms save lives?
That is a very good question. And to answer it, I have to go back to a Jesuit philosopher who taught me in high school who said, you should always tell people what you know, what you don't know, and what you believe. In the case of mammograms, we have 12 studies that show that mammograms save lives when done in women aged 50 to 75. We know that to be fact. We have one Canadian study which failed to show that it saved lives when screening women aged 40 to 49. Now, despite that, many people believe mammography saves lives for women younger than 40. And I can actually explain to you why the problem or why the debate about mammography in their 40s, if you'd like.
Sure.
The problem is when you do a mammogram, you're looking for a tumor which is white. In a young woman in her 20s, a mammogram of her breast, the breast is white. So you're looking for white tumor on a white background. As the woman ages, her breast gets less dense, and a mammogram on a woman who's in her 70s is a black background. So you're looking for something white on a black background. And so the issue seriously is just shades of gray. In women in their early 40s, it is very hard to see a tumor in the breast when a mammogram is done because the background breast is still very light gray to white. Take also the fact that very few women in their 40s have breast cancer. So mammography is a better test for women in their 50s and 60s because it's easier to see the tumor, and in that age group, the tumor is more likely to be there. Less than 15% of all breast cancers occur in women under the age of 50. And for women, the median age of getting breast cancer is somewhere around 61, 62.
So I saw that in April, the U.S. Preventive Services Task Force updated their recommendations for breast cancer screening, and it used to start at 50, and now it's suggesting we start at 40. Why is that, given what you've just told me?
Some of it is politics. Some of it is congressmen and senators were threatening the Preventive Services Task Force and said, if you don't recommend screening at 40, we're going to take your funding away. Some of it is there is a legitimate question. It might save lives. Now, one of the things that many people don't understand, even many radiologists who have been recommending screening for women in their 30s and 40s, is radiation causes breast cancer. And if you start screening at age 40 and do it every year until age 75, That's 35 doses of radiation from mammography, plus the extra radiation from the abnormal mammograms that require additional imaging. If you start screening at age 40 and you do it every other year until age 75, you've already have the radiation dose. And when the Preventive Services Task Force makes a recommendation, they make a recommendation for the entire population. And they actually look at a benefit and they look at a risk. They literally calculate how many lives do we think it's going to save and how many breast cancers and breast cancer deaths is it going to cause. Now, when we do that number for women age 50 to 75, the number of lives saved is far, far, far more than the number of lives lost or even the number of lives negatively affected. When we start screening women age 40 for the entire population again, the number of lives lost and the number of lives negatively affected actually increase versus the number of lives positively affected. Now, I keep talking about populations. We have to think about each individual woman. A woman who has a high risk of breast cancer because of family history or because of radiation treatment for lymphoma in childhood, those women, maybe they ought to be screened earlier, and maybe the screening ought to be something like MRI or ultrasound in addition to or instead of radiation from mammography. One of the problems when you're an epidemiologist is you have all the answers for the entire population, but not the answer for the one patient in front of you.
So not all mammograms are the same, though. I know that's something that you've been concerned about.
Yes. There is so-called 3D mammography, and then there's 2D mammography. 2D mammography is the old technology. 3D is the newer technology. Many people have said since it's newer, it must be better. The companies that manufacture 3D got the FDA to approve it based on studies that it finds tumors at the same rate or so as 2D mammography. Now, there are a number of places that are offering 3D mammography. There's some states that now say insurances must pay for 3D mammography. Truth of the matter is, the largest clinical trial involving women in the United States right now, sponsored by the National Institutes of Health, is a study looking at the question, is 3D better than 2D? Now, I know 3D is more radiation than 2D. I know 3D has more false positives where we ring the alarm and say there's something here, we need to figure out if it's cancer. I don't know that 3D is better than 2D. That's why the National Cancer Institute of the National Institutes of Health has this huge study ongoing. I know a number of women's advocacy groups, even some radiologists who think because it's newer, it's better and are pushing it. But the reality is it's the largest trial involving women for breast cancer at the National Institutes of Health at this time. Is 3D better than 2D?
I actually went for my annual mammogram yesterday, and they offered me 3D or 2D, and I asked them if there was more radiation in 3D, and they said there was not.
Unfortunately, that's not true.
Yeah.
I've even had women tell me that the clerk behind the desk, these are women who work with me and understand screening and do a lot. When they go get their mammogram and they're asked, do you want 3D versus 2D? 3D is a $75 upcharge that you have to pay out of your pocket. 2D is taken care of by your insurance. And they say, I'll just take the 2D. And the woman behind the desk says, don't you care about your breast health? Trying to shame them into getting the 3D.
Wow. We've also talked about, I'd like to talk about not just the quality 3D versus 2D, but I know you've had concerns over the years about mammogram vans. Can you talk to me a little bit about what they are and why they may not be as good as they're touted?
Mammogram vans were developed. They put the mammogram into a van, and the idea is we will take the mammogram to the woman as opposed to having the woman come to the bricks and mortars breast center for a mammogram. And they've often been advertised as a way to get poor women or women who have transportation issues, lack of access, getting them mammography. Many health centers around the country have bought these mammogram vans. They also happen to be great advertising. You put the name of your health center on the side, and it drives around the city or even drives out into the country to rural areas to screen women. The problem with mammogram vans is we have defined high quality mammography as looking at last year's mammogram and year before's mammogram and comparing it to the one done today. It turns out when surveyed, nearly 80% of mammogram vans around the country don't even try to find the previous mammogram to do the comparison. So they are, by definition, doing low quality screening. The quality of screening that we as medical professionals would not want to see ourselves or our wives getting. And so I don't like mammogram vans because they end up being great promotion for the health center, but they're not giving the same quality of care that we normally would. Now, the 20% of mammogram vans that do try to find previous mammograms, I think that's the right thing to do. But even when we survey them, many of them have difficulty finding previous mammograms, which it gets to a root point. So frequently our message is get a mammogram. Our message needs to be get into a program of routine, high quality mammography. And we do that much better at breast centers or breast screening centers than we do even at just radiology clinics where they do CT scans of the head or chest x-rays or MRIs and other things. We do much better at breast centers because they keep the records and they actually do the comparisons.
And I imagine, obviously, more low-income folks use the mammogram vans. Does that create a disparity in care?
Yes. Low-income people, racial minorities, especially Blacks and Hispanics, are much more likely to use mammogram vans as opposed to white middle class. And some of the disparity in outcome that we see and unfortunately have come to accept is because Black women get lower quality care as a group, especially poor women, because this is a problem for poor whites as well. They get lower quality care starting with screening, lower quality diagnostics, lower quality treatment, lower quality surgery, lower quality in terms of administration of hormones or chemotherapy to treat the cancer. We have even data to show that the quality of the pathology is lower, or the quality of the radiation therapy machines, if treated with radiation therapy, is more likely to be lowered. Poor people get treated with older, lower energy, more dilapidated radiation therapy machines in the United States. That is a fact. We've got interesting race data, by the way, in that there are 5 states in the United States where Black and white women have virtually the same death rate. In the United States as a whole, Black women have a death rate that's 40% higher than whites. Yet that's not true if you go to Connecticut. It's not true in Massachusetts and 3 other states. I can actually go this other way as well. There are 11 states in the United States where white women have a higher breast cancer death rate than those Black women in Connecticut and Massachusetts. This actually indicates that we have a problem in getting high quality treatment to Black and white women in the United States, or to all women in the United States, I should say.
It's interesting because you were very specific about, get a high quality mammogram, which I think that message doesn't get across.
Well, I actually see policymakers say 60% of Black women who are over the age of 50 are getting mammography. 60% of white women are getting mammography. The problem can't be mammography. And they don't realize the Black women who get these things on mammogram vans and other things are more likely to get lower quality mammography. It is 60 and 60, but it's not equal. And by the way, that brings up another issue that's a pet peeve of mine. We so frequently have this argument, and it's not a discussion, it becomes an argument, it's a heated argument. Should we be recommending screening for women 40 to 49? And we forget that 40% of women age 50 to 75, where, as I said earlier, we have 12 studies to show it saves lives. 40% of women age 50 to 75 do not get regular, routine, high-quality mammography. There are actually more lives to be saved by going from that 60% to even 90% of women age 50 to 75 getting mammography than if all women age 40 to 49 got regular mammography.
I want to ask you one last question, and this goes back a little bit to the 2D, 3D conversation. There's also becoming more common molecular breast imaging. So I'm guessing there's no radiation in that.
Oh, no, there is.
Oh, okay.
Yes. It's actually injection of a nuclear medicine. So It's not just radiation to the breast, it's radiation to the whole body. If we can get that radiation dose down and keep molecular breast imaging at the sensitivity and specificity that it currently is, it has the potential of being much better than mammography. I've seen some molecular breast imaging that is just absolutely astounding. You see a mammogram, and then you see the molecular breast image, and the tumor's glowing on the molecular breast image. Unfortunately, that's the radiation. And I have hope for molecular breast imaging in the future. It is currently experimental. There are a couple of places around the country that are doing just fantastic work. But again, we need to lower the radiation dose.
So you have hope for this to be a real game changer.
I do have hope that molecular breast imaging is going to be a real game changer. The images that you see are just absolutely astounding. Now, the thing about molecular breast imaging is when we do a mammogram, the X-ray, it just shows structure. And when we do a molecular breast imaging, it's a combination of structure and metabolism or physiology of the tumor. And this gets to be important because some of the tumors that we find with mammography are not genomically programmed to grow, spread, and kill. What I'm actually saying is in perhaps 20 to 30% of women who have a localized disease, localized breast cancer, that tumor, if left alone, is never going to bother that woman. We cure some women who don't need to be cured. And I want to be careful. We got studies to show that we cure a lot of women who need to be cured, okay? But we do cure some women who have something that looks like cancer, but its natural history is it won't grow and spread. With molecular breast imaging, we actually have the potential that we can look at that molecular breast image and be able to identify the overdiagnosis tumor. That's the name of the tumors that aren't going to kill versus the tumors that are going to kill. So molecular breast imaging might actually lead us to a lower rate of biopsies in the future, a lower rate of the inconvenience of a biopsy, which scares a number of women away from mammography. One argument to be careful in advocating mammography among women age 40 to 49 is the number of callbacks and the number of biopsies that end up not being cancer is quite high. And there are actually papers out there about how we scare so many women away from mammography by screening them in their 40s that they don't come back in their 50s and 60s, where we have those 12 studies to show that it saves lives.
Dr. Otis Brawley, thank you so much for joining me.
Thank you for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Fernandez-Ciceri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production management by Catherine Ricardo. Social media run by Grace Fernandez-Ciceri. Analytics by Eliza Rosen. If you have questions or ideas for us, please send us an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.